Hey guys, this is Dr. Huff. Let's look at the bias. So we are looking at the bias in terms of the epidemiological studies. So to begin with, there is something known as a observer. There is observer bias. So as name suggests, it is nothing but it is a differential ability to observe. It is a differential ability to observe. And this is a subjective bias. It is a subjective bias. Next, we move on to the interviewer bias. So this interviewer bias. So what is meant by the interviewer bias? So the interviewer asking the leading questions. So the interviewer, they ask leading questions, and this is to the subjects. So they ask leading questions to the subjects, or the interviewing cases thoroughly than the controls, or the interviewing cases thoroughly. So they ask them thoroughly than controls. So what is the method to reduce this? So how do you reduce the interviewer bias? The answer is by double binding. So by double binding, you can reduce the interviewer bias. Next bias we are going to see is known as a memory or the recall bias. There's a memory or the recall bias, the bias recall. So what happens here is, this is the differential ability. It is the differential ability of cases, differential ability of the cases as well as the controls. So it recalls a certain detail, to recall a certain detail, and it is nothing but an objective bias. It is a objective bias. So what are the methods to reduce it? The methods to reduce. So how do you reduce it? It is by the decrease time from the exposure to follow-up. So decrease in time, this will be from the exposure, to that of the follow-up. Next, we move on to the something known as a surveillance bias. So what is the surveillance bias? So surveillance bias, it means that there is active surveillance. And this leads to an increase in chance of identifying the event. So it increases the chance of identifying the event. Next, there is the reporting or the notification bias. There is something known as a reporting or the notification. Reporting or the notification bias. So it is nothing but the disease associated with the stigma are reported less. So disease which is associated about the stigma, so they are reported less. So this was a reporting or notification bias. Next, we move on to the Parkinsonian. So what is this Parkinsonian? So in terms of Parkinsonian bias, let's look at it in detail. So the Parkinsonian bias, it is when the hospitalized based control, so it is a hospital based case control studies, and it occurs due to the differential hospital admission rates. So how do you reduce it? So the reduction of the Parkinsonian bias would be by randomization, as well as you can do the matching. Then we have something known as the selection bias. So selection bias is a sampling bias. It is a sampling bias, that is a non-random allocation of subjects. There is a non-random allocation of the subjects, and that do not represent the population. They do not represent the population. And how is it reduced? It is reduced by the randomization and the matching. Randomization as well as by matching. Next is the Hawthorne bias. So what is the Hawthorne bias? So Hawthorne bias is nothing but a change in the attitude. So there's change in the attitude as well as the actions. There's a change in the attitude and the actions, and this will be of the subjects under observation. So the subjects which are under the observation, and this is reduced by the use of placebo group. So use a placebo group. Then we look at the confounding bias. So in terms of the confounding bias, the factors related to both exposure and outcome distort. The factors which are related to both exposure as well as that of the outcome, they distort the effect of exposure on outcome. So let's repeat again the factors which are related to the both exposure and the outcome. So it is and the outcome. They distort the effect. So it distorts the effect of exposure on the outcome. So how do you reduce this confounding bias? So reduction of this confounding bias is by matching. So we do matching. There is also the crossover studies. Then there is randomization. There is randomization as well as the stratification. Then is the attrition bias. This is attrition bias. What is the attrition bias? So here the participants lost to follow-up. They lost to follow-up. So the participants they lost to follow-up and have a differential prognosis than those who complete the study. Then have different prognosis than those who completed the studies. So how do you reduce this? The reduction is by randomization. Next, we will look at the Pygmalion bias. So in terms of the Pygmalion bias, there is the researchers. So there is researchers' high expectations, and this is in the efficacy. This is an efficacy of the treatment change. The treatment change the outcome of the treatment. Treatment change the outcome of that treatment. So there is a researchers' high expectations and the efficacy of the treatment change the outcome of the treatment, and this will be done by it is reduced by the binding. Next is, lastly, we look at the Neyman's. So a Neyman or the prevalence incidence bias. So this prevalence incidence bias. So it occurs due to the selective survival in prevalent cases. So it is due to the selective survival. Selective survival. This is in case of the prevalent cases, usually seen in fatal diseases. It is seen in fatal diseases and in very sick patients. So also in case of very sick patients, and they are automatically excluded because of their early death. So they are excluded. This is due to the presence of early death. So let's have another small note on the Neyman's bias. So if you look at the Neyman's bias, it is, or the prevalence incidence bias. So let's take an example. So a case control study, so CC study. So let's write case control study is carried out in the relationship between the tobacco smoking. So tobacco smoke versus the MI, acute MI. So the cases are interviewed in 1 week after the coronary attack. So you have a coronary attack. So after 1 week later, you go and compare them. So if the smoker with the AMI die more frequently. So if smoker patients die, so what they are saying is, if in case of the smoker patient, they die, smoker patients with MI. So smoker patients with the MI die more frequently. They die more frequently. Frequently they die. And the living cases will show a lower frequency of smoking. The living cases, they will show lower frequency. Living case will show lower frequency of smoking. Next is undervaluing the associations between the smoking and AMI. And undervaluing the association. This is between the smoking and AMI. So it has been shown that the bias occurs only if the risk factor influences the mortality. So you can tell the bias, it occurs only due to the risk factors. Only if the risk factors, it influences the mortality. So it influences the mortality. And this is from the disease being studied. This is from the disease being studied. So then there is something known as the ecological fallacy. So this ecological fallacy. So this is, it results when the characteristics of the group are assigned inappropriately to the individuals. This is when the results, this results when the characteristics of group, so the characteristics of the group, they are assigned inappropriately to that of the individuals. So this was all about the bias in case of the epidemiological studies. We saw various bias. To name a few: interviewer bias, surveillance bias, Burkesonian bias, Hathorne bias, attrition bias, Neyman's bias. To learn and grow daily like this, please do subscribe.